the Bald Oncologist podcast series, featuring Dr. Malwinder.
Hi everyone, welcome to the Bald Oncologist podcast. This is a special edition for Diwali. Today in the studio we have Dr. Satya, who's a consultant urologist. Hi Dr. Satya, welcome to the show.
Hi Dr. Malwinder, thanks for having me.
Sure. So we are in November right now, which is the Men's Health Month. So what should we talk about today?
So let's see, let's talk about prostate cancer.
Okay, I think that's a good start. Okay, so prostate cancer, early prostate cancer. Okay, what are the treatment options which is available for the early prostate cancer patients?
All right, so when we look at early prostate cancer, these are the group of men that you can achieve cure.
Yeah.
So aim in cancer is always cure, get rid of the cancer, and increase survival.
Correct.
So then we look at the type of cancers where we have got, low risk prostate cancer, intermediate, and high risk. So those who undergo under the low risk category, so you can actually look at them and think, okay, these are younger men maybe. Okay, so we want to try to reduce the side effects of treatment. So some of them qualify for something called active surveillance.
Okay.
Okay, so but these are only for low risk prostate cancer, meaning that these are cancers which may not spread. So when we say low risk, we are looking at low risk for it to spread elsewhere, because once it spreads, it's stage 4. Then your chance of cure is virtually zero.
Yep.
Yeah. So what we want is select these men in this group, and we try to postpone the radical treatment because you want to try to reduce the side effect.
Correct.
So that's called active surveillance. So in active surveillance, you'll discuss with your urologist and see, look, maybe I don't want to have the treatment right now because I don't want the side effects, which is erectile dysfunction, incontinence, but not in all cases. We'll discuss that later.
Okay.
And then we look at them, do serial PSA tests. PSA is a blood test to look at a prostate-specific antigen to see whether it's going beyond the threshold. And you do visits regularly, about 3 monthly. Your urologist will have a feel of your prostate to see whether it has, something has, changed. And if it has changed, then we will do a repeat MRI and a biopsy.
Okay.
Yeah. So, and this protocol can change depending on where you are in the course of the surveillance. And once you hit a threshold where, look, maybe this cancer has gone beyond the low risk, then you have the treatment. Yeah. So that's one. So for intermediate and high-risk prostate cancer, then of course, if it's localized, you want to try to remove the cancer. One of the treatment options is surgery, radical prostatectomy.
So now there's something new called robotic surgery also.
Yeah.
So what's the difference between open surgery and robotic surgery?
Okay, so prostatectomy is the same.
Okay.
So we go in, we want to try to remove the prostate, the seminal vesicles, make sure there's adequate margin. And in some cases, when there's intermediate and high risk, you want to also remove the lymph nodes.
Lymph nodes, okay.
So that's called pelvic lymphadenectomy. So we take out the lymph nodes. These are generally to stage your patients further and see whether there's any risk that this might progress or whether it's already spread to the lymph nodes.
So this is an open surgery, or they do it from the rectum or from the perineum? How do they do it?
The access is still the same. It's transabdominal.
Okay.
So we can do it open. So open radical prostatectomy was the mainstay in how this surgery was done to remove the prostate. So we go in, it's a surgery in a very tight, confined space. Very few people want to explore and do this operation on a regular basis because it is quite challenging on your body, your posture, and it's a tiring operation. You're always trying to see into the pelvis, and that area is filled with lots of blood vessels. You'll have bleeding and so on. So, and after you remove the prostate, you reconstruct, you join the bladder to the urinary passage so that these patients can pass urine later and so on.
Sounds like very complicated.
Oh, it is complicated.
How many hours does this take normally?
So usually in an open radical prostatectomy, it takes about 3 hours.
Wow. Okay.
Yeah. So, and with robotic prostatectomy, so robotic prostatectomy is a minimally invasive surgery where we have got a device which goes in, has a look at the view in a 3D manner, better vision, better lighting, and you've got instruments which have got increased dexterity, better than your own arms.
Okay.
Where you go in and resect the prostate in a more precise manner, reduces blood loss, That's one of the main thing. Because the incision is smaller, it reduces hospital stay, and your recovery is much quicker. So these are the things. And the added benefit of robotic surgery, for example, is you can preserve the neurovascular bundle.
Yeah.
So the nerve preserving prostatectomy, so nerve sparing prostatectomy, what it does is that it tries at its level best to preserve the nerves which maintain erection. Yeah. And also in the same manner, improve continence.
Okay.
So these are the, I would say, the upside of robotic surgery. But essentially, it's the same thing. You're going in and taking out the prostate.
So is it true that when you do robotic surgery, the surgeon can actually sit at the side and drink coffee while doing surgery?
Well, it is possible because you're not scrubbed in.
Okay.
But I don't know how many operating theatres will allow you to bring coffee into the operating theatre. So that's a bit of a problem. But yes, you can, access your phones. You are not scrubbed in. So you've got a sterile assistant who is actually scrubbed in with the patient once you've docked the robot in. Then you're sitting on the console. You're relaxed. You'll be operating without, confined to be seated. So
There's no stress.
Oh, it's a great relief on your back.
Okay.
Yeah, so definitely.
Okay, so I'm a radiation oncologist, so I do a lot of SBRT for prostate cancer. It is one of the modalities to treat early prostate cancer also.
Yeah.
So how do we identify which patient should go for surgery, which patient goes for SBRT?
So this is always something that we put back to the patient. So for me, from both of us do different things for the same disease. Yeah.
Same
so
outcome.
exactly. So essentially, I'm selling a Toyota, you're selling a Honda. Yeah, gets you to the same place, but it depends what the patient wants.
Yeah. Common side effects of even surgery or radiotherapy is always like incontinence, erectile dysfunction. Some if you need hormones, it's going to be like libido and all. Right?
Exactly.
These are quite common.
These are common things, but of course we have got things that we can do to overcome these problems.
Okay.
Yeah, medication, some additional surgery and so on. So it can all be managed.
Okay, sure. So thank you for coming for the show.
Thanks, Dr. Malwinder, for having me.
Thank you. So Dr. Satya, any final messages for the public?
Okay, so since it's November, Men's Health Month, so I have to remind all men, don't be in the thought that you're invincible. So get yourself checked if something is not in order. And also, happy Diwali to everyone out there who celebrate.
Yes, happy Diwali to everyone too. Thank you for watching.
The Bald Oncologist podcast series